Welcome to Rennis Care Radio. Mineral and bone disorders, MBD, are common and significant complications in patients with chronic kidney disease. CKD, known collectively as CKD-MBD, these disorders encompass a broad spectrum of mineral metabolism issues, bone abnormalities, and vascular or soft tissue calcifications that significantly impact the morbidity and mortality of CKD patients. The pathogenesis of CKD-MBD is complex and multifactorial, involving disruptions in calcium, phosphate, parathyroid hormone, PTH, and vitamin D metabolism. As kidney function declines, phosphate excretion decreases, leading to hyperphosphatemia. Elevated phosphate levels stimulate PTH secretion, secondary hyperparathyroidism, disrupting calcium metabolism and leading to further bone disease and vascular calcifications. Additionally, the failing kidneys produce less calcitriol, active vitamin D, which impairs calcium absorption from the gut and exacerbates hyperparathyroidism. Over time, these imbalances lead to various bone diseases collectively termed renal osteodystrophy, which ranges from high-turnover bone disease, osteitis fibrosa cystica, to low-turnover bone disease, adynamic bone disease. The diagnostic evaluation of CKD-MBD includes biochemical tests, bone imaging studies, and, occasionally, bone biopsies. Biochemical markers such as serum calcium, phosphate, PTH, and 25-hydroxyvitamin D levels are routinely monitored. Advanced imaging techniques, including dual-energy X-ray absorptiometry, DEXA, scans and radiological assessments, help evaluate bone density and structural changes. Bone biopsies, although invasive, provide the most definitive information about bone turnover, mineralization, and volume. The management of CKD-MBD aims to balance calcium and phosphate levels, reduce PTH levels, and manage bone health. There are several treatment strategies for CKD-MBD, including the following 5 approaches. Number 1. Phosphate binders. These medications bind phosphate in the gastrointestinal tract to prevent its absorption and mitigate hyperphosphatemia. Examples include calcium-based binders, sevelamer, and lanthanum carbonate. Number 2. Vitamin D therapy. Active vitamin D analogs, e.g., calcitriol, paracalcitol, or nutritional vitamin D supplements are used to suppress PTH production and improve calcium metabolism. Number 3. Calcimimetics. Agents like cinacalcet effectively reduce PTH levels by increasing the sensitivity of the calcium-sensing receptor on parathyroid glands to extracellular calcium. Number 4. Dietary management. Restricting dietary phosphate and maintaining adequate protein intake are crucial components of managing CKD-MBD. And number 5. Emerging therapies. New treatments, such as monoclonal antibodies against PTH and innovative bone-targeting agents, are under investigation and hold promise for future management options. CKD-MBD represents a complex interplay of mineral, bone, and cardiovascular alterations that significantly affect the quality of life and survival in CKD patients. Early recognition and comprehensive management of these disorders are critical to improving clinical outcomes. As research progresses, understanding of the molecular pathways involved in CKD-MBD will likely lead to more targeted and effective treatments, enhancing the care of CKD patients and potentially reversing or preventing the complications associated with these disorders. Thank you again for joining us here on Rennis Care Radio.